Welcome to the audio digest of the American Journal of Psychiatry. This is Dr. Susan Schultz with highlights for the month of December 2008. Please note that the full text of all articles may be viewed online at ajp.psychiatryonline.org, including all author affiliations and disclosures. This month, our Treatment in Psychiatry feature will focus on prison inmates with attention deficit hyperactivity disorder. Several of our research articles relate to biological rhythms. The first reports about a prospective study on the association between sleep disturbance and the recurrence of depression among older adults. The second study tracked melatonin circadian rhythms in pregnancy and the postpartum period among depressed women and those with a personal or family history of depression. We'll also highlight a trial of interpersonal and social rhythm therapy for patients with bipolar disorder, specifically its effect on occupational functioning. Then we'll turn to a study of trauma, resilience, and recovery in a high-risk African American population. We'll also feature a report showing an association between reading skills in the general population and a gene for dyslexia. We'll conclude with two articles on deficits in markers of GABA-aminobutyric acid in schizophrenia. We'll also include an editorial on GABAergic signaling and neuronal synchrony. We'll begin with a treatment in psychiatry, which discusses a common clinical problem. This month, Kenneth Applebaum examines the assessment and treatment of correctional inmates with ADHD. The article begins with two hypothetical case vignettes, Mr. A and Mr. B. Mr. A is an inmate in a medium security prison who's recently been diagnosed with attention deficit hyperactivity disorder. His parents report that he had academic difficulties from the 3rd or 4th grade. He didn't complete high school, and in prison he enrolled in GED courses. The instructors confirm that he still has difficulty in organizing his work and finishing projects. After ADHD was diagnosed, the prison psychiatrist prescribed a 2-month course of bupropion, but no improvement was seen. Mr. A has also enrolled in a prison educational group on ADHD. Mr. B is an inmate in a maximum security prison who stated his complaint as, "I need something to help me concentrate and keep me out of trouble." He reports that he was a poor student and was diagnosed with ADHD as a child, and that he took methylphenidate before incarceration. However, he won't consent to contact with his family or sign a release for past treatment records. He complains that it now takes him a long time to read a book or complete a letter, and he hasn't enrolled in any educational or work programs in prison. He has received several disciplinary reports and has had positive urine screens for benzodiazepines and opiates. He says he isn't interested in trying any medication other than a stimulant. The prescription of controlled substances in jails and prisons opens a Pandora's box of potential woes for psychiatrists. Easy access to the diagnostic criteria used by prescribers, along with coaching by cohorts, can result in sophisticated attempts at malingering. Problems occur even when stimulants are prescribed appropriately. Legitimate patients may be pressured into turning over their medications to more predatory inmates. Despite monitoring, opportunities for diversion persist. Some individuals become quite skilled at stashing pills in their cheeks. Others may swallow and then regurgitate medications. Also, the handling of controlled substances makes large demands on nursing staff. Many correctional practitioners strongly discourage use of stimulants. Nevertheless, ADHD among inmates causes impairment and distress, which can have disruptive effects within the prison. To ensure a valid diagnosis, a prudent correctional psychiatrist will require a diligent effort by the inmate to provide some corroborating information on prepubescent impairment. Corroboration can include school records, recollections by family members, or other third-party reports. Current functioning is the most critical issue. Difficulty with recreational activities rarely justifies the risks associated with stimulant treatment. Symptoms that hinder participation in programming, educational activities, and work assignments are more relevant, and these difficulties can often be verified by work supervisors, teachers, programming staff, healthcare providers, or security officers. ADHD can also lead to impulsive behaviors that may result in disciplinary infractions, but some inmates may create disturbances in an attempt to get medications. In the correctional setting, there are compelling reasons to use non-stimulant medications first. Atomoxetine is the only non-stimulant approved for ADHD, but clinical studies have also shown varying degrees of efficacy for other medications, especially bupropion, tricyclic antidepressants, and to a lesser extent venlafaxine. Psychiatrists can reserve stimulants for inmate patients who have not responded to an adequate trial of one or more non-stimulant medications or who have contraindications to such trials. When stimulants are needed, immediate release medications may have advantages in prisons. Nursing staff can crush them, which decreases the risk of diversion. Evidence of misuse, abuse, or diversion of prescribed stimulants should prompt immediate discontinuation. In the absence of coercion, an inmate who diverts medication demonstrates a lack of commitment to treatment. Similarly, misuse or abuse of any substance raises concerns about the appropriateness of treatment. Other treatment options include non-pharmacologic interventions. Education about ADHD can help ease frustration, enhance self-esteem, and teach organizational skills. Group therapy with other inmates who have ADHD can have similar benefits. A willingness to participate in these activities indicates the inmate's investment in treatment. In contrast, the absence of a commitment of time and energy should call into question the inmate's distress and need for medications, and possibly the diagnosis itself. The recommendations for the patients in the two case vignettes aren't the same. Although Mr. A reports no previous ADHD diagnosis or treatment, his parents recall symptoms before age 12. In contrast, Mr. B reports a history of ADHD and stimulant treatment, but refuses to release past records or consent to family contact about his history. Mr. B also won't cooperate with testing or treatments other than stimulants. The most significant consideration regarding Mr. B, however, is his lack of involvement in activities that might justify using stimulants to aid functioning. His report of difficulties with leisure activities and his disruptive behaviors by themselves would not override the contraindications to treatment in this setting. In contrast, Mr. A has participated in the evaluation and other treatments. Most important, reliable third parties confirm that his symptoms cause difficulty with his educational and work activities despite his apparent motivation. These findings, along with the lack of response to a non-stimulant medication, support the use of stimulants. Now let's turn to our research articles on biological rhythms. In a prospective study, Hyung-Jin Cho and colleagues examined sleep disturbance and depression recurrence in community-dwelling older adults. The study screened more than 2,800 subjects aged 60 and older. Those with the evidence of a current or past history of depression were identified, as well as a group of age and gender-matched participants without a history of mental illness. At baseline, these subjects underwent a psychiatric diagnostic interview. The Pittsburgh Sleep Quality Index was used to screen for clinical sleep disturbance, which was defined as a score greater than 5. Follow-up assessments were conducted at 6 weeks, 1 year, and 2 years from baseline. A prior history of depression was reported by 145 subjects. None of them fulfilled the criteria for a current depressive disorder. Nearly 1/3 were using antidepressant medications, and the median time since the last depressive episode was about 10 years. At baseline, the subjects with prior depression had worse sleep quality. Nearly half were classified as having a clinical sleep disturbance. However, nearly 18% of the comparison subjects were also classified as having a sleep disturbance. During the 2-year follow-up, only one comparison subject developed depression. Among the group with prior depression, however, the cumulative incidence of depressive disorders was 17%. All of these cases developed after at least 10 months of full remission and more than 8 months after the baseline assessment. The occurrence of depression was also associated with sleep disturbance. Depression was 3 times as likely among the subjects with sleep disturbance at baseline as among those without sleep disturbances. However, this relationship appeared to be operating primarily in the group with prior depression, as only 1 case of depression occurred in the comparison group. In addition, the association was independent of other depressive symptoms, sociodemographic characteristics, chronic medical burden, and use of antidepressant medication. The authors also tested whether prior depression and sleep disturbance were associated with the severity of depressive symptoms as measured by scores on the Beck Depression Inventory. These relationships were also significant. The association between baseline sleep disturbance and symptom severity during follow-up was also significant in the comparison group. Our other article on biological rhythms is by Barbara Perry and colleagues, who found plasma melatonin circadian rhythm disturbances during pregnancy and postpartum in depressed women and women with personal or family histories of depression. Plasma melatonin has been found to be the best measure of circadian rhythmicity in humans, and its circadian rhythms are of lower amplitude in some, but not all, depressed patients. In this study, pregnant women and those in the first postpartum year were screened by telephone. Those included in the study agreed to multiple overnight hospital stays, but were permitted to bring their child if necessary. Those with major depression were required to have stopped taking antidepressants at least 2 weeks before the start of the study, or 4 weeks for fluoxetine. The diagnosis of depression was based on having a score of at least 14 on the Hamilton Depression Scale and at least 10 on the Beck Depression Inventory for at least 2 weeks. Those with postpartum depression also had to have a score of at least 10 on the Edinburgh Postnatal Depression Scale. Women who met the entrance criteria arrived at the research center at 4 p.m. Following 1 night of adaptation, they received an intravenous catheter at 5 p.m., and blood was drawn every 30 minutes from 6 p.m. to 11 a.m. Subjects slept in the dark with an eye mask. Nurses threaded the catheter through a porthole in the wall and drew blood samples from an adjoining room in order to minimize sleep disturbances. Of the 25 pregnant women, 10 were diagnosed with major depression. Melatonin concentrations between 2 and 11 a.m. were lower in the women with depression than in those who were healthy. Melatonin secretion increased over the course of pregnancy in the healthy women, but not in those with depression. Pregnant women who had a personal or family history of depression had earlier melatonin offset times. A higher number of previous depressive episodes was associated with earlier melatonin synthesis and baseline offset times. There were 24 women in the postpartum study, 13 of whom were depressed. In contrast to the pregnant women, in this group the depressed women had significantly higher melatonin levels across time points relative to healthy women. Individual paired comparisons for the postpartum group showed that the most reliable differences in melatonin secretion occurred from 6:30 to 9:30 a.m. Disturbances in circadian rhythms can also be therapeutic targets. Ellen Frank and colleagues examined the role of interpersonal and social rhythm therapy in improving occupational functioning in patients with bipolar I disorder. This treatment is a modular, manual-based therapy aimed at helping patients stabilize their daily routines and sleep-wake cycles. It is designed to stabilize endogenous circadian rhythms, provide insight into the bidirectional relationship between mood and interpersonal events, and help patients resolve interpersonal problems related to grief, role transitions, role disputes, and interpersonal deficits. All of the patients were also receiving pharmacotherapy, and their symptoms had remained stable for at least 4 weeks. Intensive clinical management was used as the control condition. It consisted of education about bipolar disorder and medications, instruction about sleep hygiene, review of symptoms and side effects, medical and behavioral management of side effects, and nonspecific support. More than 60 patients were randomly assigned to each treatment group. Acute treatment lasted approximately 35 weeks. Occupational functioning was assessed by means of the Social Attainment Scale, and ratings were made at baseline, at the end of treatment, and after 1 and 2 years of maintenance treatment. The main effective treatment assignment did not reach conventional levels of statistical significance. However, there was a significant treatment by time interaction. For the participants assigned to interpersonal and social rhythm therapy, the initial improvement in occupational functioning was more rapid than for the patients assigned to intensive clinical management. For both groups, improvement tended to be sustained during the maintenance phase. Although the participants assigned to intensive clinical management showed much slower improvement, by the end of 2 years of maintenance treatment, their occupational functioning was virtually identical to that of the patients assigned to interpersonal and social rhythm therapy. The treatment had a differential impact on occupational functioning in men and women. Women assigned to interpersonal and social rhythm therapy showed the most rapid and marked improvement, while men receiving this treatment showed slower changes in vocational functioning, followed by those who did not receive acute interpersonal and social rhythm therapy. Now let's switch to the studies of risk in normal populations. In the first one, Tanya Alim and colleagues explored trauma, resilience, and recovery in a high-risk African American population. To develop a cohort of individuals exposed to trauma, participants were recruited from primary care clinics at Howard University Hospital in Washington, D.C. 41% of the patients attending the clinics agreed to complete a self-report questionnaire, which asked about the lifetime occurrence of traumatic events in 17 categories. More than 250 respondents had been exposed to at least one severe traumatic event, and they were given a structured interview to determine psychiatric diagnoses. About 1/5 didn't have any lifetime psychiatric disorders and were considered resilient. A third had one or more past disorders but had recovered, and nearly 1/2 had current psychiatric illnesses. Several self-report questionnaires were completed to identify psychosocial factors associated with resilience and recovery. The group without lifetime psychiatric disorders had a significantly lower lifetime trauma load. However, trauma load did not significantly differ between the recovered and currently ill groups. Sexual assault was not more strongly associated with current illness than non-sexual trauma, perhaps because of the severity of the non-sexual assaults. Female gender was predictive of current illness. A key factor associated with both resilience and recovery was having a purpose in life. A feeling of mastery was also significantly associated with recovery. Higher frequency of attendance at religious services was related to resilience, but simply considering oneself to be religious or spiritual was not. The next article relates to genetic risk. Silvia Paracchini and colleagues report the association of a dyslexia susceptibility gene with reading skills in the general population. The population comprised children between the ages of 7 and 9 in the Avon longitudinal study of parents and children in Great Britain. This is a large longitudinal cohort for which reading-related phenotypes were available for more than 6,000 individuals. The reading measures included 2 dichotomous measures and 5 continuous measures. The gene studied was KIAA0319, which is located on chromosome 6p. The authors genotyped 4 single nucleotide polymorphisms that previously had showed association with reading disability. They also tested 2 haplotypes, one with 3 SNPs that was previously identified as a risk factor, and another with 2 SNPs that was previously observed to be protective. The minor allele of one of the SNPs was significantly associated with poor performance on the continuous measures of reading and spelling. This SNP effectively tags the haplotype associated with greater risk of reading difficulties, and the risk haplotype itself also showed association with reading problems. As in previous research, this association was stronger when the analysis was controlled for IQ. Now we'll conclude with 2 articles on gamma-aminobutyric acid, or GABA. The first reports a proof-of-concept clinical trial by David Lewis and colleagues, subunit selective modulation of GABA type A receptor neurotransmission and cognition in schizophrenia. The experimental drug was a compound similar to a benzodiazepine that selectively activates GABA A receptors with alpha-2 subunits. 9 men with chronic schizophrenia received the new medication for 4 weeks, and 6 received placebo. At the end of treatment, there was no difference between groups in BPRS total scores. There was only one difference on the repeatable battery for the assessment of neuropsychological symptoms. The patients taking the experimental drug had significantly greater improvement on the index of delayed memory. 3 cognitive tests were also given. The NBAC test evaluates working memory by testing the ability to remember sequential letters. The AX continuous performance test requires the subject to pay attention across a delay interval in order to overcome the tendency to respond prematurely. This tendency was also tested by a task called the Preparing to Overcome Prepotency, or POP task. This is a cued stimulus response reversal paradigm, and it requires increases in cognitive control through maintenance and use of information about context. The group taking the experimental drug had a significantly greater improvement on the POP test. Their improvement was also greater on the NBAC task, although this difference fell short of statistical significance. Within-group differences on the continuance performance test showed that the scores for the placebo group did not change. Scores for the experimental group did improve, but not to a statistically significant degree. The authors also measured EEG gamma band oscillations during the POP task. In healthy people, gamma band oscillations in the dorsolateral prefrontal cortex increase in proportion to the working memory load. A previous study showed that patients with schizophrenia had reduced gamma activity during a cognitive control task. Over the 4 weeks of the Lewis trial, the patients taking the new drug had greater increases in frontal gamma band power during the POP test compared to the placebo group. From treatment, we'll turn to genetic differences identified by Michael Bullock and colleagues, who report altered expression of genes involved in GABAergic transmission and neuromodulation of granule cell activity in the cerebellum of schizophrenia patients. One of the most consistent molecular findings from schizophrenia research is the dysfunction of specific subsets of interneurons expressing GABA. Given their role in modulating excitatory output, dysfunction in specific interneurons may mediate some of the positive, negative, and cognitive symptoms of schizophrenia. GABA-related deficits have already been well characterized in the prefrontal cortex and limbic system, but there have been few studies of them in the cerebellum. However, the cerebellum has been shown to contribute to cognitive functioning through its connections to the prefrontal cortex. The authors conducted a post-mortem study of 13 patients with schizophrenia and 13 non-psychiatric comparison subjects matched for sex, age, and post-mortem interval. Messenger RNA transcripts of several GABA markers and neuromodulators were measured. These indicated that levels of enzymes involved in GABA synthesis are lower in patients with schizophrenia than in healthy subjects, and that GABA transmission is also less. Abnormalities in the expression of neuromodulators of GABA activity in granule cells were also seen. The patients had been taking atypical or typical antipsychotics. To test the effects of medication on the expression of the identified genes, the authors administered haloperidol, clozapine, or a control substance to rats for 6 months. Both antipsychotics altered expression of several GABA-related genes, but several of the effects from haloperidol and clozapine did not match each other or the abnormalities seen in the patients. The Lewis and Bullock studies are the subject of the editorial by Shahram Akbarian, Restoring GABAergic Signaling and Neuronal Synchrony in Schizophrenia. It begins with the molecular biology and pharmacology of the GABA-A receptor. These receptors are heteropentameric ligand-gated chloride ion channels. Typically, they are comprised of 2 alpha subunits, 2 beta subunits, and 1 GABA subunit. When activated, they effectively hyperpolarize mature neurons through the changes in the chloride conductance. Benzodiazepines act as positive allosteric modulators by facilitating the action of presynaptically released GABA, and they bind at the interface of alpha and gamma subunits. However, the benzodiazepine sensitivity of the receptor shows important differences and is highly dependent on the specific alpha subunit. There are 6 alpha subunits in the human genome. 2 of these, alpha 4 and alpha 6, are insensitive to benzodiazepines. On the other hand, currently prescribed benzodiazepines have a high affinity and intrinsic affinity for GABA A receptors with the alpha 1 subunits, which are predominant in the human cerebral cortex. These characteristics could explain the sedative effect of these drugs, as well as a further impairment of prefrontal function in subjects with schizophrenia. In contrast to the currently prescribed benzodiazepines, the experimental drug in the Lewis study causes much less sedation because its activity occurs selectively at GABA A receptors with alpha 2 and alpha 3 subunits. Importantly, alpha 2 subunits are highly enriched at the axon initial segment of pyramidal neurons, which comprise the output relay of the cerebral cortex. However, the axon initial segment consists of androgen-induced protein, and these proteins are among the postsynaptic targets of a subtype of GABA neurons that express parvalbumin, a calcium buffer protein. These neurons show a specific firing pattern described as fast spiking. Intriguingly, the parvalbumin-positive GABA neurons regulate and coordinate the timing of pyramidal neuron firings, and so they are essential for orderly gamma oscillations and memory function, which become disrupted when fast-spiking synaptic currents are downregulated. Post-mortem brain studies indicate that parvalbumin-positive neurons are hypoactive in schizophrenia in the cerebral cortex. Lewis and colleagues therefore hypothesized that enhanced signaling through GABA A receptors with the alpha 2 subunit at the axon initial segment of pyramidal cells could improve gamma oscillations and prefrontal cognitive function in schizophrenia. Indeed, the data from this trial provide the first empirical support for this hypothesis, although more studies with larger cohorts and subjects of both genders will be necessary to reach a definitive conclusion. The cerebral cortex was the brain region examined in the Bullock study. Many of its 10 lobules are interconnected with the frontal lobe via relays in the pontine nuclei and a return projection through the thalamus. This study focused on a portion of lobule 7 that is interconnected with the prefrontal cortex. The authors confirmed for their schizophrenia cases some of the alterations in cerebellar mRNA and proteins that were previously reported in other brain collections. These alterations include a deficit in expression of the 2 rate-limiting enzymes for GABA synthesis. The increase in GABAergic mRNAs in the cerebellar cortex of rats treated with antipsychotics suggests that the observed decrease in the clinical samples is related to the disease process, not medication. The study is based entirely on quantifications of RNAs extracted from tissue, and therefore it remains to be determined which of the 4 subpopulations of GABAergic neurons in the cerebellar cortex are affected: Purkinje, stellate, basket, or Golgi cells. However, as the authors indicate, many of the observed mRNA changes in their study point to the Golgi neurons. This is interesting because these cells play a key role in inhibiting the glutamatergic type of cerebellar neurons, granule cell neurons. Thus, in striking analogy to the cerebral cortex, cerebellar cortex function in schizophrenia could also be compromised by a deficit in inhibitory control over excitatory circuitry. The context of the 2 studies has more substance to it than mere academic interest. Cognitive deficits are a predictor of functional outcome in schizophrenia, and a role of GABAergic systems for some of these deficits is emerging. Therefore, it's interesting that a subset of GABAergic genes, including those for the GABA A receptor alpha 2 subunit and for the rate-limiting enzymes, are epigenetically modified throughout development and aging of the human cerebral cortex. Thus, it is possible that targeted interventions for specific GABAergic deficits, given even before the appearance of overt psychosis in high-risk individuals, could significantly alter the course of illness or even prevent it altogether. This concludes the audio highlights of the December issue of the American Journal of Psychiatry. We invite you to our website, ajp.psychiatryonline.org, for the full text of these and other articles. We also welcome comments regarding this audio. They can be emailed to Jane Weaver. Her email address is jweaver@psych.org. Thank you.